Thank you for this lovely introduction. When centuries ago, gradually, giving birth, sorry, I have to find out how this works. Here we go. Moved from home to hospital, it was hailed as progress. Dr. Semmelweis noticed the higher childbed fever mortality rate, and he introduced hand washing. He reduced the mortality rate of mothers by 90% and published his data, yet it did not change practice. Now I bring this up here because with abortion we find ourselves perhaps in a very similar situation where evidence and practice are not working in harmony, at least not totally. This is the task ahead and why you're all here, but we are calling for change. The NHS monitors complications after abortion. It uses two processes for this. First of all, the abortion notification system. This is compiled by those who actually carry out the abortion and is limited to what the data that they can capture. Because that is limited, the NHS uses additional data from the hospital episode statistic. And then there is a final complication rate that also includes when there is evacuation of retained products of conception that needs to occur. I think you immediately can see where there is a gap, because what about any complications that are beyond the abortion clinic but don't make it into a hospital episode? And additionally, if we're looking at what kind of data is counted as a complication to abortion, they are all very acute complications, and they do not include anything of what my previous speaker was talking about. And also, where are the longer-term consequences that perhaps are in the field of non-gynecology and yet make an impact? So here, for instance, we have a study from earlier this year that shows a correlation between abortion and pregnancy loss. Now, the authors did try and drill down the data to differentiate between induced abortion and a natural miscarriage. And while the data was fairly similar, from the raw data, it was not always possible to establish the causes of the miscarriages. However, my question in this area is, when stress from any kind of pregnancy loss can have such an impact on future cardiovascular status, how come we have a health service that really only becomes active in investigating any woman once she has had 3 miscarriages? And here we are learning the complexity of research. In this triangle, you see, first of all, that the public observe, and it could be any phenomena. They raise questions and pose them to the researchers or the medical team, who then come up with a hypothesis of what requires further investigation. They go to the money pot holders, and then all of this at any stage is relayed and published through the media. The relative lack of studies into longer-term consequences of abortion can be visualized if there is, for instance, a taboo or a lack of interest or even a conflict of interest in any of those groups that would or have the power to advance research. Historically, it has been claimed that abortion, when it was introduced, would actually save lives of mothers. But this is not necessarily so. In this particular study from Mexico, it shows that over a 10-year period, the states that had less permissive abortion legislation exhibited a lower maternity mortality rate than those with more permissive legislation. And if we're just looking within the Western world, various countries, and compare the maternal mortality rate, let's say of Malta and Portugal and Poland, they are very favorable in comparison to other countries with more permissive abortion legislations. In fact, this is a headline from earlier this year. There is concern about the maternal death rates in the UK. Now, I am no way saying that abortion is here the only factor. There are many factors that contribute, but our healthcare system, as I will show later, has a disconnect that we need to acknowledge. Looking beyond, in this study here, this is not just looking at direct maternity mortality, but it's looking at it for any cause of death over time. And Dr. Reardon, who did this research, found that within 180 days, there was a statistically significant difference between those who chose an early abortion and those who chose to give birth. And this difference lasted over years. We see here the trend over 10 years. And also, not just that, it was also cumulative. More abortions meant a higher risk for overall mortality, which he concludes higher rates of death from suicide, accidents, homicide, and some natural causes, such as circulatory disease, may be from elevated stress and risk-taking behaviors. Now here comes the elephant in the room: abortion and breast cancer. If I read here what the medical institutions, and there's quite a few, and I'm listing the conclusion of one of them, they claim that the better statistics are showing that there is no link between abortion and breast cancer. But let's just see this slide here. As the rate of abortion increases, with a 10-year delay, we are finding that the breast cancer risk is also going up. In the UK, we're finding it's 1 in 8, and it's hitting younger women, premenopausal women too. So what about all these studies? Over 100 studies, and the majority of them show a strong link or a mild link. The higher the red line, the stronger the link. The medical establishment do agree that having a baby young and breastfeeding is protective towards breast cancer. But why do studies from countries where those tendencies are widespread still show an increase in breast cancer rates? And here is statistics from India, Iran, and Bangladesh, where women typically marry young and have children early. Another meta-analysis here from China, again showing that the more abortion somebody has, the more is the increase in terms of breast cancer risk. If any of you care to find out more about this, I really recommend. Oh, sorry, I'm behind in my slides, in my clicking. If anyone want to find out more, I recommend this Hush film documentary. It is now freely available, actually, on Vimeo. And it goes into detail about all the studies that I've mentioned, but also the responses that are coming from the medical establishment. And it explains the biology behind it all, why it makes sense there should be more and increased cancer risk. Another aspect that is addressed is also, what about subsequent pregnancies that then lead to birth after an abortion previously? And we find that there is an increased premature delivery rate. In the States, It literally doubled between 1990 and the early 2000s. And in this country here, it is, the latest statistic is from 2022, it is 7.9%. That's 53,000 children that are born early. And we should be asking, why does this happen? Here in one study, they look at it and come to the conclusion that a previous induced termination of pregnancy is associated with a significant increase in risk in low birth weight or preterm baby. And here in another study, they are looking at it, and you can see that in the lowest line, there's a risk factor is doubled for a baby in a subsequent pregnancy to be born in younger than before 24 weeks gestation. And yet, that's this one here. And yet, at a general surgeon meeting that was specifically looking at the area of preterm births, they weren't willing to even discuss that. They had a vote and didn't want to discuss it, even though their own data in the appendix showed immutable medical risk factors associated with preterm birth was also a prior first-time trimester-induced abortion. The final example that I want to give is about infertility. We hear about rising infertility rates, and the World Health Organization has looked and tried to quantify things. In their report, out of the over 12,000 studies that they looked at, they then selected 133. Just one of them mentions abortion. And their conclusion is that the history of at least one abortion was significantly associated with secondary infertility. Another study here that looks at abortion and infertility, in its conclusion writes, while there appears to be a general consensus that there is no association between abortion and infertility, amongst the publications that do exist, there is nevertheless evidence to the contrary. And he concludes, if it were known that abortion was an underlying cause of infertility, it would be an ethical and legal requirement that the medical professionals inform women before consent for abortion is obtained. And finally, abortion to reduce multiple pregnancies. Here an example post of a woman who speaks insightfully about her experience. She says, if I had conceived these twins naturally, I wouldn't have reduced this pregnancy, because you feel like there's a natural order that you don't want to disturb. And she's saying, but the pregnancy was so consumerish to begin with, and this became yet another thing we could control. What we're recognizing is there is a disconnect in what the woman describes, and this same is also happening within the medical field. And it starts with what is probably a second elephant in the room, contraception. Contraception suppresses temporarily, or even longer, fertility. It does not seek to understand fertility. Artificial reproductive medicine skips over the cause of infertility. It does not try to resolve the underlying issue. The reproductive technology physicians, or the artificial reproductive technology physicians, do not have an involvement in the obstetric care. So there's a disconnect between what happens at the start of conception and what happens later when the child is born. And the same counts for perinatology. It is focused, very specialized on the later part of pregnancy and disconnects itself from actually the conception cycle. Now, I don't believe that quoting a lot of statistics will change women's hearts that are in crisis. I think it needs more of that. what we are seeing and what I hope to have shown you is that the woman's body is very medicalized, literally from teenage years until post-menopause. And this is the bit that allows for change. And I'm showing you 3 examples of programs that seek to change this. We cannot get women to feel positive about themselves when they actually feel just their existence requires a doctor to give them a prescription. We need to teach young girls that they are special and that they have gifts such as ovulation, gestation, and lactation. These are not illnesses, these are their gifts. Instead of medicalizing, we need to educate. Instead of suppressing, we need to foster an understanding of nature. Instead of abdicating the control, we need to inspire a sense of wonder in women. Because if she can say yes to herself, then it is much easier for her to also say yes to when she conceives. Thank you very much.